Welcome to another episode of Surgery from Snazzy Surgeon. Today, we're diving deep into thyroidectomy, specifically hemithyroidectomy and total thyroidectomy. It's a common procedure, but as we all know, the nuances are critical for optimal patient outcomes. Let's unpack the key consideration.
Absolutely. Both are fundamental, aren't they? Hemi and total. Understanding the indications, the technical points, it's essential. Let's maybe start with hemithyroidectomy.
Good idea. So just to define it clearly first.
Right. Hemithyroidectomy is the removal of one complete thyroid lobe, along with the isthmus that connects the two lobes.
Okay. And when are we typically looking at doing just a hemi? What are the main scenarios?
Well, a primary indication one we run into quite a bit is diagnostic.
For the tricky nodules.
Exactly. You have a solitary thyroid nodule, the FNA comes back indeterminate, maybe inconclusive, particularly if you're suspicious of a follicular lesion. Doing a hemi gives you the whole lobe for histology. You need that full architecture to make the call, especially with follicular patterns. You just can't tell from cytology alone sometimes.
That makes sense. Cytology can only tell you so much. What about clear-cut benign disease?
Yeah, for benign conditions that are definitely confined to just one lobe, hemithyroidectomy works well. Think follicular adenoma or a toxic adenoma causing hyperthyroidism just on one side. Also, sometimes you see a dominant cold nodule within a goiter that's otherwise only on one side, a unilateral multinodular goiter. Hemi can be the answer there, too.
And where does it fit in for thyroid cancer? It seems less common now, but still has a role.
It does, particularly for low-risk differentiated thyroid carcinoma, so papillary or follicular cancers. We're talking tumors typically between 1 and 4 centimeters, importantly with no signs of extrathyroidal extension, no metastases. Honestly, the preference is really stronger for the smaller ones, under 1 centimeter if there aren't any other worrying features.
So size and containment are key. Smaller, localized cancers.
Right. The idea is less surgery can be equally effective for these low-risk cases, plus you preserve some native thyroid function.
You mentioned some selected cases, too. What falls into that category?
Sometimes in older patients, maybe with an asymmetrical goiter causing compression, but they're not great candidates for a bigger operation. A hemi might relieve symptoms. And occasionally it comes up if there's a real concern about adherence to lifelong thyroid hormone replacement. But that's a very careful discussion, balancing risks.
Always a balance. And we have to remember the possibility of needing more surgery later, right?
Absolutely critical point. If that final pathology after a hemi comes back showing malignancy that, warrants more extensive treatment, maybe aggressive features, unexpected invasion, then a completion thyroidectomy is needed. That's removing the remaining lobe. Patients have to understand that possibility up front.
Sets expectations. Okay, let's pivot to total thyroidectomy then. Removing the whole gland.
Yes, total thyroidectomy is the removal of both lobes and the isthmus. Occasionally you hear about near total, leaving a tiny remnant, but mostly it's the complete removal.
And the indications here are generally more extensive disease.
Generally, yes. For thyroid cancer, it's the go-to for higher risk or multifocal disease. Papillary or follicular cancers that are 4 centimeters or larger, any sign of extrathyroidal extension, or any metastasis nodes or distant. Also for medullary thyroid cancer, especially if it's familial or bilateral, and prophylactically for known RET mutation carriers because their risk is so high.
And the radioactive iodine connection.
Crucial. Total thyroidectomy is necessary if you're planning post-operative radioactive iodine therapy. You need to remove as much thyroid tissue as possible for the RAI to be effective in targeting residual cells or microscopic disease.
Makes sense. What about benign conditions driving a total thyroidectomy?
Hyperthyroidism is a big one. Graves' disease, particularly if the patient also has ophthalmopathy, the eye issues. Total thyroidectomy offers the most definitive control. Also for toxic multinodular goiter, especially if it's large or causing symptoms. And if medical therapy for thyrotoxicosis fails, surgery, usually total, becomes the option.
And just managing large goiters, even non-toxic ones.
Right. A large bilateral multinodular goiter causing significant compressive symptoms, trouble swallowing, breathing, or even just for cosmetic reasons sometimes. Total thyroidectomy prevents recurrence. And certainly for any large goiter, toxic or not, that's actually compressing the trachea or threatening obstruction.
Any other less common indications mentioned?
Briefly, yes. Things like familial non-medullary thyroid cancer, where there's a strong family history, and also radiation-induced thyroid cancers from previous neck irradiation.
Okay, so whether it's hemi or total, the preoperative preparation is obviously key.
Yeah.
What are the universal steps?
Always. You absolutely have to check the coagulation status, make sure there are no bleeding risks. Good hydration is important. And patient counseling, it's paramount. They need to understand their diagnosis, exactly what surgery is planned, why, and all the potential risks. Really thorough discussion.
Absolutely. Informed consent is crucial. What if the patient is thyrotoxic? That adds another layer of prep, doesn't it?
It really does. The main goal there is achieving euthyroidism, getting those thyroid hormone levels back to normal before surgery. This massively reduces the risk of complications like thyroid storm, so we use antithyroid drugs like methimazole or PTU. Beta blockers, often propranolol, are essential to control the heart rate, tremors, those adrenergic symptoms, and often Lugol's iodine for maybe 7–10 days just before surgery. It helps decrease the gland's blood flow, makes surgery a bit easier, less bleeding.
So the propranolol helps with symptoms and also that T4 to T3 conversion.
Yes, it helps manage the catecholamine effects and does inhibit some peripheral conversion of T4 to the more potent T3. Getting them euthyroid is really the priority for safety.
Okay, that makes sense. What about just the routine blood work and tests everyone gets?
Pretty standard stuff. Hemoglobin, white count, maybe an ESR, bleeding and clotting times, basic urine analysis, electrolytes, urea, blood sugar, and definitely blood group and cross-match just in case, though transfusions are pretty rare in routine thyroids.
Imaging, cardiac assessment.
Chest x-ray is standard, and an ECG, especially important for anyone with toxic goiter or pre-existing heart conditions, to check their cardiac function.
Are there more specialized tests we might need sometimes?
Yes, depending on the situation. Neck x-rays, AP and lateral, can show tracheal deviation or compression from a big goiter. A full ENT exam might be needed, maybe concerns about voice or airway. Sleeping pulse rate can be a marker for toxicity. Neck ultrasound is almost routine now, gives great detail on the gland, nodules, nodes. And of course, the thyroid function tests T3, T4, TSH. Baseline serum calcium is important before messing with the parathyroids. FNAC results guide the plan. Radioisotope scans can help differentiate causes of hyperthyroidism like Graves versus a toxic nodule.
And one really crucial baseline test.
Vocal cord assessment. Indirect laryngoscopy before surgery is essential to document baseline vocal cord function. You need to know if there's any pre-existing issue before you operate near the recurrent laryngeal nerves.
Absolutely critical baseline. Okay, let's move into the OR, anesthesia and positioning.
Standard is general anesthesia with endotracheal intubation. Gives secure airway control. Positioning. Patient is supine. We like about a 10-degree head elevation, helps reduce venous pressure a bit. For a Hemi, the head is usually turned slightly away from the site of surgery. And the key thing is neck hyperextension. Get that neck stretched out for good exposure, usually done with a rolled sheet or a bolster placed between the shoulder blades. Head needs support too, often a foam rubber ring.
That positioning really opens up the field. So incision time.
Right, the classic Kocher incision. It's a transverse collar incision, usually placed in a natural skin crease. Good landmark is about 2 finger breadths, say 3 to 4 centimeters above the sternal notch. Aim for symmetry. Gentle upward curve follows skin lines for a better cosmetic outcome. Then you divide subcutaneous tissue and the platysma muscle underneath. Can use cautery or sharp dissection.
And once through the platysma, flap elevation next.
Correct. We raise subplatysmal flaps. So dissecting in that plane just deep to the platysma. Superiorly, you go up to about the thyroid cartilage. Inferiorly, down to the suprasternal notch. Then place self-retaining retractors to hold everything open. Sometimes, for deeper access, especially big glands, you might need to raise the flaps a bit further. A Joel's retractor can help there too.
Exposure achieved. Next layer is the strap muscles. How are they handled?
Sternohyoid, sternothyroid. Usually we make a midline vertical cut in the deep cervical fascia between them. Then you can separate the muscles and retract them laterally. That usually gives enough exposure. But if you have a really large goiter extending way out or down low, you might need to actually divide the strap muscles for access. If you do divide them, you must repair them carefully at the end of the case.
Okay, now we're getting to the core of it, dealing with the blood supply, the vascular pedicles. Let's start with the middle thyroid vein.
If it's present, yeah. The middle thyroid vein often comes off laterally, drains into the IJV. It's usually one of the first vessels you take to help mobilize the lobe. Ligate it and divide it close to the gland. Use silk or Vicryl, maybe 3-0. Key here is careful dissection. Avoid digging around blindly near the internal jugular vein.
Got it. Then moving superiorly, the superior thyroid vessels.
Right. The superior thyroid artery and vein at the upper pole. You need to dissect these out carefully. The critical thing here is ligating them very close to the thyroid gland itself. This helps protect the external laryngeal nerve, which runs nearby, often close to the artery. Using fine instruments like right-angled forceps or an aneurysm needle helps place those ligatures precisely.
Protecting that external laryngeal nerve is key for voice pitch. Now, inferiorly, this is where the recurrent laryngeal nerve is really at risk.
Extremely critical area. The inferior thyroid artery branches and veins need ligation, again, right near the gland capsule. This helps preserve blood supply to the parathyroid glands, which are usually nearby. But the absolute rule here is identify the recurrent laryngeal nerve first. Before you clamp or ligate any branches of the inferior thyroid artery in that area, you need to see the nerve, usually in the tracheoesophageal groove, and protect it throughout this dissection. That's paramount.
Nerve identification first, always. Okay, viscels controlled. Now mobilizing and removing the lobe itself for a hemithyroidectomy.
For a hemi, once the vessels are secure, you gently retract the lobe medially towards the midline, cut the areolar tissue attachments, keep identifying and protecting that recurrent laryngeal nerve as you mobilize posteriorly. Then you encounter Barry's ligament, that tough, fibrous attachment to the trachea. Divide it sharply, staying right on the thyroid capsule to keep away from the nerve. Finally, dissect the isthmus off the trachea and divide it sharply where it joins the other lobe. And the Hemi specimen is out.
And for a total, you essentially just do it all again on the other side.
Exactly. Once the first lobe and isthmus are removed, you turn your attention to the contralateral side and repeat the entire process meticulously. Ligate superior, middle if present, inferior vessels. Identify and preserve the nerve on that side. Mobilize the lobe, divide Barry's ligament, and then excise the remaining lobe and any attached isthmus. That gets you the whole gland out.
You mentioned always taking the isthmus, even in a hemi. Why is that standard?
Yes, the whole isthmus comes out in both procedures.
Yeah.
Main reason is to minimize adhesions forming right there in the midline, over the trachea. Could make future surgery harder, theoretically, just cleaner to take it all.
Makes sense. Specimen is out. Next big step, hemostasis.
Crucial. Have to be meticulous. Make sure all the named vessels ligated are secure. Maybe double ligate the bigger ones with silk. Use bipolar cautery carefully for any small oozing points in the thyroid bed. Some surgeons use harmonic scalpels or Ligaseal devices, which can help seal as they cut. But the final step is always a really careful inspection of the whole thyroid fossa. Make absolutely sure there's no active bleeding before you close.
What about drains? Are they used routinely?
Not routinely, no. It's more selective. We might place a closed suction drain if it was a particularly large gland, a lot of dissection, maybe a concurrent neck dissection, or if hemostasis was difficult to achieve. If used, they typically go under the strap muscles and come out in a day or two.
So, surgeon's judgment call. Okay, ready for closure? How's that done?
In layers. If the strap muscles were divided, reapproximate them first, usually 3-0 Vicryl or similar absorbable suture. Then close the platysmal layer carefully, again with absorbable sutures. This gives good support. Skin closure, we aim for the best cosmetic result. Often a subcuticular stitch, like 4-0 monocryl, buried under the skin, no stitches to remove, or sometimes skin staples, usually just a very light dressing or sometimes none at all.
All right, patient's closed, heading to recovery. What's the focus immediately post-op?
Keep the head elevated, maybe 30 degrees, helps with swelling. Then it's all about monitoring. Watch closely for bleeding, any sign of hematoma formation, neck swelling, difficulty breathing. Stridor is an emergency. Start checking serum calcium levels fairly early, within 6-12 hours, and serially. Looking for that drop that signals hypercalcemia from parathyroid issues, and assess the voice. Any hoarseness, breathiness could indicate recurrent laryngeal nerve bruising or injury.
And long-term, the hormone replacement.
After a total thyroidectomy, it's lifelong L-thyroxine replacement, no question. The body has no thyroid hormone source. After a hemithyroidectomy, it's variable. The remaining lobe might compensate fully or it might not. So you monitor their thyroid function tests post-op. If they become hypothyroid, then they'll need L-thyroxine supplementation as well, maybe just a lower dose.
So quite a difference in long-term management there.
Definitely. A key part of the pre-op discussion about which procedure is appropriate.
Well, I think we've covered the essential steps and considerations in both hemi and total thyroidectomy pretty thoroughly. The decision-making, as you said, really hinges on understanding the indications, meticulous technique, and that vigilant post-op care.
Indeed. It's a procedure where attention to detail at every single stage is what leads to the best outcomes for our patients.
Thank you for listening to our podcast. See you in the next episode.